Thank you all for joining. I think just so that we can keep to time, we are going to start now. So welcome to this webinar on diabetes and genomics. Next slide, please. I think before we start, we just have some housekeeping. So the webinar is being recorded and the recording will be shared with all participants afterwards, as well as being uploaded to our website and YouTube sites. Please can I ask for you to all turn off your cameras and mute your microphones during the presentation, and when you're not speaking, to minimize any background noise. And throughout the session, please feel free to add your questions, thoughts, comments to the chat. We will try to answer as many as we can during the Q&A at the end, time permitting. And finally, if you've not already, please do complete our pre-event survey, and the QR code is there to the right. I think we can go on to the next slide, please. So for those who are not aware, today is World Diabetes Day, and it is observed annually on this day. So World Diabetes Day was established in 1991 by the International Diabetes Federation and World Health Organization to raise awareness about diabetes. And this day honors Sir Frederick Banting. It's his birthday. And he co-discovered insulin with Charles Best in 1922. But the day serves to highlight the impact of diabetes, which affects millions globally and leads to serious health issues like blindness, kidney failure, and heart disease. And in 2022 to 2023 in the UK, more than 5.6 million people were estimated to be living with diabetes, which was an all-time high. So today we'll be hearing from an esteemed expert in the field of diabetes and genomics, and I'm really delighted to welcome and introduce Dr. Catherine Owen. So Dr. Owen is an associate professor at the University of Oxford and consultant at the Oxford Centre for Diabetes, Endocrinology and Metabolism. Thank you, Dr. Owen. Are you ready to take it away? You're on mute.
Yes, thank you. Thank you so much for inviting me to talk today, and welcome everybody on, as we say, World Diabetes Day. So I don't know how many, what people's specialties are, whether you're mainly genetics people or mainly diabetes people or mainly something else. We're just interested people. But we're going to talk a bit about diabetes today. Please do put your questions in the chat, and if I'm a bit too technical about diabetes, put a diabetes question in as well. I'm happy to answer everything. All right. So let me just get my slides up. So we're going to start by talking about a patient. So this is Jenny, who's a patient who came to my clinic in Ocdem, and she had been diagnosed with diabetes at the age of 20. She presented with a typical diabetes symptom of thirst and had a raised blood glucose of 13, but was well otherwise. And she didn't have signs of being acutely unwell with ketone production. But because of her age, she was diagnosed with type 1 diabetes and she was started on insulin. So a very standard presentation and treatment. But reasons which we were not quite sure about. She'd stopped taking her insulin after about 3 months. And it was several months later that she ended up attending the clinic in Oxford. I mean, normally we would try to see people with type 1 diabetes quite intensively over the first few days and weeks after diagnosis. So this was a bit of an atypical pathway. But anyway, I saw her. She was lean with a normal BMI. She had a high HbA1c. For those of you not familiar with these numbers, a normal HbA1c will be below 43, and the target HbA1c in diabetes is 48. So her HbA1c was high, but she was on no treatment. More questioning revealed that she had a 3-generation family history of type 1 diabetes. And another important investigation that we did was her pancreas islet autoantibodies, which is a marker of type 1 diabetes, and they were negative. So we're now thinking about what's the likely diagnosis in Jenny, because it doesn't look entirely typical for type 1 diabetes. But what's in favour of type 1 diabetes? Well, in favour is her young age. So most people getting diabetes at the age of 20 would have type 1 diabetes, and also that she's got a normal BMI, so she's not obese. In favour of type 2 diabetes, which is increasing in younger people, would be the fact that she didn't have a very acute presentation. She didn't become acutely unwell or have diabetic ketoacidosis and have to come into hospital. She's also got negative antibodies, which is more in keeping with type 2. And of course, not needing insulin it would be a big feature of type 2 diabetes. But of course, we know that this talk is not just about type 1 and type 2 diabetes, so could it be something else? And that's important because when we think about how we manage diabetes, it depends on what the etiology, what the cause of the diabetes is. So for type 1 diabetes, treatment is insulin. For type 2 diabetes, we know that we would not use insulin diagnosis, but would give lifestyle advice plus maybe a tablet called metformin. And then if the diagnosis is one of these something else's, it might not be insulin or metformin that we need. So this is a slide I've been using for a long time, and actually it's become a bit more complicated over the past few years. Because when we think about type 1 diabetes now, we don't just think about putting someone on insulin. We might be thinking about using immunotherapy to modify the process of the diabetes, because it's an autoimmune disease, and that's something we're doing a lot of research on. We're going to be using what we call intensive insulin, which and give people education on how to adjust that so that people can take 4 or 5 insulin injections a day according to what they're eating. And we might use technology like insulin pumps or artificial pancreases. In contrast, for type 2 diabetes, it's not just a bit of lifestyle change. We know that if people lose a significant amount of weight, they can put their diabetes into remission. And we also have many medications now which modify cardiovascular risk, which is one of the biggest comorbidities in type 2 diabetes. Whereas if it's one of those something else diagnoses, we may be able to use precision medicine. So this is where you use a medicine that's specifically tailored to the etiology. In this case, we're talking about genetic etiology. So what could some of those something else's be? And this is where we use this term, maturity onset diabetes of the young, or MODY. And this is a group of monogenic or single gene causes of beta cell dysfunction. So as we know, the beta cells are the cells in the pancreas that make insulin. And so these monogenic causes affect the beta cells mainly. And this is a small percentage of young onset diabetes in the UK. And if you think about all diabetes, it'll be less than 1%. And the diabetes that's caused by monogenic causes, it's classically a young age of onset. So often in the second and third decade, and most by the age of 45. It's a autosomal dominant condition, so you're quite likely to get a parental history of diabetes. It runs in families. Because it's not type 1 diabetes, you don't get these islet autoantibodies. And another feature of type 1 diabetes is that people tend to have very low or absence of insulin secretion, whereas other kinds of diabetes, you get persistent insulin secretion, although it's not enough to control diabetes. And because it's not type 2 diabetes, you get absence of obesity and insulin resistance. So a collection of features which could be quite characteristic. And we know now that there are quite a number of genes which may be involved, and I'm going to talk about those individual genes over the next few slides. But you can see it's not just one condition, it's a heterogeneous condition. And the most common type of MODY that we see in adults is due to mutations in these genes called HNF1 alpha or HNF4 alpha. And I've put them together because they cause a very similar clinical picture or phenotype. And this is your classic autosomal dominant genetic condition. So you see it in multi-generational families, parents, grandparents affected, and often first cousins. So it's a very typical genetic condition. And characteristically, this causes you to have a normal blood sugar as a child, but to get this progressive beta cell dysfunction or reduced insulin secretion, and so that you need treatment as you get older. And this is a kind of diabetes that's responsive to a group of drugs called sulfonylureas, and I'm going to talk a bit more about that later, but that's where your precision medicine comes in. And there's a few other features that we might see, and we also see that we can get vascular complications in this kind of diabetes if blood sugars aren't kept on target. So in contrast, the other kind of MODY that we tend to see in our clinics is called glucokinase MODY due to mutations in the glucokinase gene. And this is the commonest kind of MODY in children, but we see it at all ages. And this is very interesting because what it does is it causes a resetting of the level of glucose at which people start producing insulin. So normally, if you don't have diabetes, as your glucose rises above 4, then you start making insulin, and it means that you bring your glucose back to the baseline quite quickly and within a couple of hours of eating something with carbohydrate in. So that's what puts your blood glucose up. Whereas the people with glucokinase MODY start producing insulin a couple of millimoles of glucose higher, so maybe around 5 or 6 level. And so what that leads to is what we call fasting hyperglycemia, so raised fasting glucose when you wake up in the morning. It's quite mild, and the important thing is it's still regulated by the body, which most kinds of diabetes aren't. So you still produce insulin as your glucose gets higher, but everything's shifted a couple of millimoles higher. And the important thing about this kind of diabetes or hyperglycemia, and again, I'll talk about this a bit later, is that you don't necessarily find that drug treatment is very effective in altering your blood glucose or HbA1c, and that's because your body's still regulating your glucose. And that means that you don't get very high glucoses, so you don't get vascular complications of diabetes, which is obviously very important. And if you're a young person or a child and you've got an asymptomatic hyperglycemia, so not presenting with type 1 diabetes with lots of symptoms and being very unwell, but if you just found coincidentally to have high blood sugar, about 50% of those people will have this glucokinase MODY. So it's quite important to think about it and diagnose it. There's a couple of rarer kinds of MODY. I'll mention HNF1 beta MODY. This is a condition which causes developmental disorders, not just of the pancreas, but also of the kidneys largely. And so people present with renal cysts and can get kidney failure. They may also have autistic spectrum features and behavioral problems. So there's a lot of parts of this that are outside of the pancreas. It's not just diabetes. And this one is not responsive to sulfonylureas. Then we've got mitochondrial diabetes, and those of you in genetics may know about mitochondrial disease. So this is mutations in the mitochondrial genome, which is inherited through the female line because of mitochondria, the energy production in the organs in the cell, are maternally inherited. And this causes diabetes, but also, again, a multi-system disease with neurological problems, cardiomyopathy, muscle weakness, and sometimes we refer to maternally inherited diabetes and deafness, because deafness is one of the commonest neurological features you get with this. And the diabetes is due to reduced insulin production, so it's a beta cell problem. And in practice, the phenotype can be very varied, but we do pick it up with people who are coming to the diabetes clinic. Much rarer than any of the other kinds of monogenic diabetes, but worth mentioning, is neonatal diabetes. And this is diabetes diagnosed in babies, basically, before 6 months of age. It's pretty rare, and there are a lot of very rare causes of this. But what's important to us as adult diabetologists, and actually as pediatric diabetologists as well, is that about a third of them are caused by mutations in something called the potassium channel, which is, I'll show you a picture of that in a second when we're talking about the beta cell. But this is very involved with switching on insulin production. And the key thing about neonatal diabetes is that sometimes people can changed treatment from insulin to tablets, even after many, many years of being on insulin. So we recommend that you always investigate people diagnosed with diabetes as a young child or baby, because you may be able to make an important difference to their treatment. And in the rarer kinds of neonatal diabetes, it may be the first sign of a multi-system disorder. So you may find that it's going to predispose you to other features. I've just been talking a bit about the beta cell, which is the cells in the pancreas that make insulin. And this shows some pathways of insulin production in the beta cell. And we can see that we know where many of these genes are acting in the beta cell. So we know where glucokinase is acting, we know where HNF1 alpha and HNF4 alpha are acting, and we know where this potassium channel. I don't know if I've got if anybody can see the pointer here. Sorry if you can't, but the where I've got this little arrow saying sulfonylureas, this is where this is the potassium channel, which is the thing that's involved in neonatal diabetes. And the reason why sulfonylureas are so important in some of these kinds of diabetes is that they can switch on insulin production at this potassium channel, and so lead to insulin returning to normal insulin secretion. So we know where all these things are acting in the beta cell. You don't need to be aware of that for clinical practice, but it just explains why they have the features that they do. So let's go back to our patient, Jenny. We talked about whether she might have type 1 or type 2 diabetes, but could she have monogenic diabetes? So what's in favour of that? Well, she's got a mum with diabetes, she's young age. And the other thing, which is quite, it sounds a bit vague, it doesn't look exactly like type 1 or type 2 diabetes, but actually that can be the way you pick up these people, that they're not very typical of, they don't fit in either box very well. So you kind of think, could it be something else? So what happened with Jenny when she came to my clinic? Well, we know that she had high blood glucose and high HbA1c, so we thought we'd put her on treatment. So we put her on gliclazide, and we did genetic testing, and that showed that she did indeed have an HNF1 alpha mutation, the commonest cause of MODY in adults in the UK. And her blood glucose responded very nicely to gliclazide, bringing her HbA1c down to target at 48. And this all happened a few years ago, and she remains on target. So she had a good outcome to her story. Okay, so just introduce you to another patient who came to clinic a few months after Jenny did. So this was a more standard referral, someone with a high HbA1c who the GP thought needed more input from the specialist service. She'd been diagnosed with diabetes at a young age and had been on insulin since diagnosis, but had always been managed by her GP. She'd never been to a hospital clinic. She was on a relatively small dose of insulin, 26 units a day, but had a high HbA1c, well above the target of 48, and at the time was not doing any monitoring or blood glucose testing. She also had a strong family history of diabetes in her mother and in some of the maternal relatives. And a little note in the letter, which made us take quite a lot of notice, was her daughter was diagnosed with type 1 diabetes a year ago and then noted to have MODY. So that's not a very common thing that we see in referral letters. So it immediately, made me think what could be going on. And what was going on was actually her daughter is Jenny, our first patient. So we did genetic testing and we found that Sarah had the same HNF1 mutation as her daughter, which wasn't that much of a surprise. And she commenced gliclazide as well, although because she'd had diabetes for a long time, we didn't immediately stop her insulin, but we helped her with reducing it. But in fact, she responded very well to gliclazide and was able to stop insulin completely after a couple of weeks. And after many years of having a high HbA1c, her HbA1c fell to target. And not surprisingly, she was absolutely amazed to be able to stop insulin after 26 years of diagnosis of diabetes. And, it's not that surprising, because when people are diagnosed with type 1 diabetes, we tell them if they stop insulin, they're going to die. Well, she didn't die because she didn't have type 1 diabetes. So it was an amazing story. So we're talking about this clinical observation that people with HNF1 alpha MODY respond very well to these drugs called sulfonylureas, of which gliclazide is the most common one we use in clinical practice. And we've actually got some science to back that up. And this was a study that was done more than 20 years ago now, where we took people with HNF1 alpha MODY and people with type 2 diabetes. And on this chart, the purple is MODY and the blue is type 2 diabetes. And the what we're seeing here is the drop in glucose levels between treating those people with gliclazide or treating them with metformin. So metformin is the standard treatment for type 2 diabetes, and you can see that that works equally well in both these kinds of diabetes, giving you a drop in glucose of about 1 millimole. Whereas if you've got MODY and you use gliclazide, the drop in glucose is about 4 or 5 times bigger, and we can show that they respond extremely well to this treatment. And what we can do now is we can use something called a continuous glucose monitor to monitor glucose in people with diabetes. And this shows the difference between being on no treatment on the left-hand side and being on a very, very small dose of gliclazide. This is a quarter of the smallest tablet you can take, so it's powder basically. But if you look at what's happening with the blood sugars and how many people are in this target range, the green range, you can see that it goes from 36% to 90% when you take a very small dose of gliclazide. And if you look at the traces below, you can see that the trace on the right on gliclazide is very much flatter compared to the trace on the left, which has got peaks for meals and is quite often running above 10 a glucose of 10. So that's another way of showing how well people with MODY respond to gliclazide. And the other important thing is that gliclazide involves taking a tablet once or twice a day, whereas insulin involves injecting insulin probably 5 times a day or being on an insulin pump if you've got type 1 diabetes. So the intensity of treatment is so much different. So that's why it's so important to get this diagnosis right. Okay, so let's talk about another patient. This is a lady with gestational diabetes, so diabetes arising in pregnancy, but going away outside of pregnancy. And I saw her in the antenatal clinic when she had a baby ultrasound scan at 32 weeks in her 4th pregnancy. And she'd had gestational diabetes in all of these pregnancies. She'd initially been screened due to a family history of diabetes, so we screen people at around 26 weeks of pregnancy in the first time they get it, and then at the beginning if they've had it before. So she'd been picked up in all her pregnancies. She was a bit atypical for gestational diabetes because she had a very slim BMI at 19, and she was of white British ethnicity. So people at highest risk of gestational diabetes are people who are obese or who are of non-white ethnicity. So she was a bit atypical. She was, however, taking insulin because she had a raised fasting glucose. And so we did genetic testing due to this atypical picture of gestational diabetes, and also because she had a raised fasting glucose. And we found that she had a glucokinase mutation, and this is the one that causes raised fasting glucose. And we pick it up in pregnancy because we're testing people's glucose levels, and also because typically the fasting glucose that you see is a little bit higher than the target we have for gestational diabetes. So people get picked up and they get put on treatment. So alluded already to the fact that in this glucokinase mode, you don't necessarily need treatment. And this is some data that shows what happens to your HbA1c, your long-term glucose test, between being diagnosed with type 2 diabetes or type 1 diabetes, and then finding out that you've got glucokinase MODY. So the black line is the before genetic diagnosis, and the white sorry, the black boxes before genetic diagnosis, the white boxes after genetic diagnosis. And you can see that whether you're on oral hypoglycemic agents, OHAs, or you're on insulin, your HbA1c glucose level doesn't change after you stop taking those treatments when you get diagnosed with glucokinase Modi. So we've shown that because it doesn't make any difference, treatment can be withdrawn when the diagnosis is confirmed. And so the other thing to say is, well, does it make any difference to have glucokinase Modi? Does it make you, does it give you health problems? And this is a study comparing 99 people with glucokinase Modi compared to 83 with type 2 diabetes and 91 who were non-diabetic. And the people with glucokinase Modi were nearly 50 years old. So that meant that they'd had this raised fasting glucose and slightly raised blood glucose since they were born, basically, or even before they were born. And so they'd had a long duration of exposure compared to the people with type 2 who'd been diagnosed in their generally around their 30s, and so they'd had about 20 years of diabetes. And you can see that all the different kinds of health issues that you might get with diabetes, microvascular or macrovascular complications, or needing laser for retinopathy eye disease, were extremely low and comparable to the control patients without diabetes in the GCK patients, whereas the people with type 2 diabetes had 30% or more of these complications, even though they'd had less exposure to high glucose. And we can see that HbA1c was lower in glucokinase Modi, but still a bit higher than the normal, so giving them impaired fasting glucose. So we can see that they have a good outcome despite not being on treatment for diabetes. So that's a good news diagnosis for people who've been told they may have type 2 diabetes. Because we picked up our patient in pregnancy, it's just take a second to talk about what happens in pregnancy, because this is the time when people come to the attention of doctors, and it is affected by whether the baby has inherited the mutation or not from one of their parents. And I'll just go quickly through the influence on birth weight with all the different situations you can get. So say you're a mum, like our patient with glucokinase Modi, but you don't pass on the mutation to your baby. So you've got a high glucose, and this is similar to a standard gestational diabetes. Your baby is exposed to high glucose. Your baby produces more insulin because of that, and that causes an increased birth weight. And many of these babies have high birth weight and need to be delivered early. However, if you're the 50% of babies that have inherited the glucokinase mutation, your mum's blood glucose is exactly perfect for your insulin secretion, because you're going to start secreting insulin at the same level as your mum did. So you have appropriate insulin levels when you're, this is when you're still in the womb, and so you get appropriate insulin secretion and normal birth weight. So knowing the glucokinase mutation in these people in the antenatal clinic can actually, whether the baby's got it, can actually affect their outcome and how we treat the mums. It's similar with the dad, actually. So if your dad's the one with the glucokinase mutation, and your mum doesn't have diabetes, obviously, and the baby doesn't have the mutation, then everything's in normal situation, normal blood glucose, normal insulin in baby, normal birth weight. But if you've inherited the glucokinase mutation from your dad, then you actually need a higher blood glucose to produce insulin as a baby in the womb, and so you produce less insulin and you actually have a lower birth weight. So we can see about a 500-gram difference in birth weight between these situations. So it's quite significant, and something that we are very aware of in the antenatal clinic. Okay, so let's go back to thinking about finding Modi in our patients. So if we can either be labeled as type 1 or type 2 diabetes. So if you're got a label of type 1 diabetes, which patient should have Modi testing? So what we're looking for are key features of type 1 diabetes that are not found in MODY. So this is evidence of autoimmunity, so your autoantibodies or your autoimmune genetic risk. Or a key feature of MODY that's not shared in type 1 diabetes, that in MODY you maintain some insulin production, which we measure using something called C-peptide. So when should we use these different tests? So close to diagnosis, we would use islet autoantibodies. So these are the name of 3 of the islet autoantibodies we use in the diabetes clinic. And we use them at diagnosis of diabetes in children and young adults. So most people with type 1 diabetes, 80 to 90%, would have at least one of these antibodies. So if you don't have any of them, you might not have type 1 diabetes, even if clinically we think you do. And also, some people who look like they have type 2 diabetes have these antibodies and actually have a slower form of type 1 diabetes. So it's useful in those people as well. It doesn't cost very much. You only have to do it once. And if you do a study in children using antibodies, so this is a study from a childhood diabetes registry in Norway, and it's Scandinavian studies are always very good, and they captures 96% of all children with diabetes in Norway. And so they screened all these children for 2 diabetes autoantibodies, GAD and IA2, that should say, and about 12% of them were negative for both those antibodies. So then, in those people who were negative for both those antibodies, they checked them for MODY, and they found that a small percentage of the antibody negative children had MODY. And so that was only 30 children out of nearly 4,000 children who were labelled as type 1 diabetes. So it's a small percentage, it's less than 1%, but it's actually pretty important to find that out if you're the 30 children who don't need to be on insulin. So, and as I say, for the sake of doing a test that's relatively cheap to start with, then you can find the people who need MODY testing. And this is actually in our UK guidelines now to do antibody testing in children and young adults. So that's using antibodies. If we want to use the this C-peptide test to see whether they're still making insulin, you might do that years from diagnosis, because we're looking down the line, and normally this would decline after diagnosis in people with type 1 diabetes. So when would we use C-peptide? To find out when someone on insulin, particularly from diagnosis, is insulin deficient, which generally means they've got type 1 diabetes. So you have to send it with a glucose, because it's stimulated by glucose. And you can actually do this repeatedly over years to see how people's insulin production is declining. You can do it at any time during the day, or you can do it in urine. And when we looked at this in our patients in the Oxford clinic, about 10% of them had a positive C-peptide more than 3 years after diagnosis, and 10% of those had MODY. So again, we're finding a small percentage of people who didn't have type 1 diabetes in our clinic. Another test we can use, which is a test that's just coming into clinical practice, is something called a type 1 diabetes genetic risk score. And those of you who are geneticsy kind of people will be more familiar with these polygenic risk scores than clinical people. But the basis of it is that type 1 diabetes runs strongly in families. And this is due to a gene called HLA, or an area of the genome called HLA, which is what predisposes you to autoimmune conditions. And you can measure genes that give you or variants in the genome that give you a higher risk of getting type 1 diabetes. And if you combine these all together, you get a higher score if you're at risk of genetic risk of type 1 diabetes compared to if you're not. So you can do it in an individual, do this test in an individual, and compare it to what the score that people would get if they had type 1 diabetes, and it tells you whether you're genetically predisposed to type 1 diabetes. So it can be another useful tool for seeing if this is type 1 diabetes. And if you plot these out on a little graph, you can see that in yellow here, we've got the genetic risk score in people with type 2 diabetes, so they don't have an increased genetic risk of type 1. And you can see it's quite separated from the people with type 1 diabetes. So that's this is something that's sort of coming into clinical practice. Okay, let's think about the other question. So which adults labelled as type 2 diabetes should have MODY testing? And this time you're thinking about the key features of type 2 diabetes that are not shared with MODY. So this would mainly be your features of insulin resistance and obesity. So raised blood pressure, high cholesterol, high triglycerides, and fatty liver. So people with MODY don't tend to have that. And a key feature of MODY compared to type 2 diabetes would be young age of onset, because classically people with type 2 diabetes are older at diagnosis. Now, that's something that is changing because there's so many more young people aged in their 20s and 30s who are getting type 2 diabetes now. So this becomes a less useful discriminator. And the other thing that's not a very good discriminator is family history or a parent with diabetes. And the reason for that is that not because MODY doesn't have, people with MODY don't have parents with diabetes, because they very often do, but people with type 2 also have parents with diabetes, so it's not a very good discriminator. So it actually can be quite hard to pick out the features which you can use to separate young type 2 from MODY, and probably the most powerful one is BMI. Another tool which you may have heard of is this MODY calculator produced by the genetic testing lab in Exeter. And this is an app or a web page where you can plug in some simple data like age of diagnosis, BMI, whether there's a parent with diabetes. And it gives you the probability of MODY by comparing those features to a gold standard group of people with MODY compared to a group with type 1 and type 2 diabetes. So this can help you if you're not very confident at saying, does this person have features of MODY? This can help you pick out the people who are at high risk. It's got some limitations. So at the moment, it only looks at people up to the age of 35. So there are a few people diagnosed with MODY at an older age. It doesn't at the moment use the biomarkers like C-peptide or autoantibodies. And it's also currently only validated in white Europeans. So for your young onset minority ethnic patients, you can't use it to calculate the risk of MODY, but they are trying to develop it so it becomes more useful in some of those situations. So that's another tool that you can find on the internet. Okay, so how might we go about implementing this precision medicine in monogenic diabetes? And I think that really important is to get it right at the beginning. So make a proper assessment of newly diagnosed people. So we've talked about, this is a bit of a busy chart, but we've talked about how we might check islet cell antibodies, and if they're positive, that it's likely to be type 1 diabetes. We might, if the antibodies are negative and there's features of obesity or insulin resistance, then that's likely to be type 2 diabetes. And then you can look at whether this is classic MODY, your HNF1 alpha or your glucokinase MODY, or if you've got other multi-system features and it's your mitochondrial or your HNF1 beta MODY. So this kind of little chart can give you an idea. It's just another tool you can use. But we're testing in Oxford, we test everybody we think might have type 1 diabetes who's been sent to hospital as new type 1. We go through this process with all those people and look at their autoantibodies and their clinical features, and try and do, first of all, we try and weed out the people who don't really have type 1 because they've got type 2, and also we test people for MODY if they're eligible. The other thing to do is what I call look for the low-hanging fruit. And those are people who are obviously standing out like a sore thumb. So like the lady in the gestational diabetes clinic who had a BMI of 19, and clearly she wasn't typical. or when you see people who've got a really strong family history, so they really look like a monogenic family. And then the other people who you might pick out are people who've got another clinical feature, like your diabetes and deafness in mitochondrial diabetes, or your diabetes and renal disease in HNF1 beta. And then if you really want to do a project, you can go away and take all your people in your clinic labeled as pre-existing type 1 and check a C-peptide in all of those, and you will find people who've got MODY, and you would never ever have considered that they had MODY. A bit like our patient Sarah, who had the daughter with MODY. How many people would have picked that up if she hadn't had a daughter with MODY? The only way you could really do it is checking C-peptide. So genetic testing for MODY is funded on the NHS. It's in the Genomic Test Directory. The clinical features for eligibility are there, and it's genetic testing is fully funded if those criteria are met. And I'll just finish off with a word from a patient. This is a lady called June who comes to my clinic. She said, "I've been a diabetic for over 40 years. With each new doctor I'd seen, I had to give a lengthy explanation of my history, not type 1. The label was all unusual rather than MODY." And then we started a MODY clinic in Oxford where we understood the difference. And so she appreciates that she doesn't have to start off by explaining everything to her doctor. And also we were able to identify her daughter as a carrier of the gene, and she is able to be monitored for diabetes because she's at high risk of developing diabetes, and also when she was pregnant she was able to be monitored for gestational diabetes. So I am going to stop there, and I will stop sharing my slides. And any questions? I'll see if there's any in the chat.
Yes, there is one in the chat there. Thank you very much for that really informative presentation, and which really highlights the critical role of genomics in understanding this condition. So there is the one question in the chat, and that's from Konstantinos.
Yeah, I can see it. So
yeah.
So we're asking how many hidden cases of HNF1 alpha are out there? Yeah, well, that's a very good question. Well, so this was looked at a few years ago. So there are and we were able to look at it because there are certain areas in the country which diagnose a lot of MODY, and that's that where around where the Exeter lab is, because they're very aware of it, and also there are pockets of high awareness like my clinic in Oxford and a clinic in Edinburgh, and a few other places where people go out and look for MODY. And at that time, this is about 10 years ago, they estimated that about 80% of people are undiagnosed and wrongly labelled as type 1 or type 2 diabetes. We would hope now it's a little bit better because a couple of years ago, we had a really big educational, national educational project to try and train healthcare professionals to be able to pick out MODY, attend an education course, and start really looking for it in their clinic, and saying that every diabetes clinic in a hospital should be able to pick up these people because it's part of our specialist role really as diabetes consultants. Your other question about biobank data. So there is actually UK biobank data on this. It shows that there are people out there who've got what we would think would be pathogenic mutations in HNF1 alpha and HNF4 alpha. They don't all have diabetes. So this is becoming a bit geneticy and technical, but it's likely that the penetrance of diabetes in families who have got diabetes is higher than in families that don't have diabetes, so people in the population. And that's probably because there are other things which cause diabetes to be to come out, other genetic causes, other environmental causes. So I think the most important place to start looking for it is in our diabetes clinics, in our antenatal clinics, and in general practice. if you see people who are not fitting in that type 2 box because they're very lean or very young at diagnosis. And I absolutely agree. It would be great if more people could come off insulin, partly for quality of life and partly because insulin's a very complicated and expensive treatment, and we'd rather have people taking tablets. So, thank you. Any other questions? Anyone want to stick their hand up and ask a question? Oh, here we go. There's another question in the chat. So this is a question about the glucose tolerance tests used to diagnose gestational diabetes. So if you and can we use raised fasting glucose on a glucose tolerance test for gestational diabetes to look for glucokinase MODY? And absolutely you can. And if you look at the if you look in the genomic testing directory at the eligibility for glucokinase testing, we say that anybody with a fasting glucose over 5.5 who is non-obese could be eligible for glucokinase testing. And the obesity is under 30 in white Europeans or under 27 in people from minority ethnic populations. And so if you have those, if you can do an audit of your gestational diabetes clinic and try and pick out those people, and they're eligible for glucokinase testing if their fasting glucose is over 5.5. We tend to see not a very high 2-hour glucose as well. So if you see a 2-hour glucose that's, for instance, diagnostic of type 2 diabetes, so it's gone very high, that would be less likely to be glucokinase because they tend to not have a high 2-hour. Question on diabetes plus renal issues. So I think the first thing to say is that we're thinking about a rare kind of MODY called HNF1 beta, and MODY on its own is rare. So most people who have diabetes plus kidney problems don't have HNF1 beta MODY. But if you see people who have got renal cysts and young onset diabetes, then it might be that's not type 1 or that's not type 1 diabetes, then that could be HNF1 beta MODY. But it's probably a question for a specialist to make it, to look at the case and make a decision about whether they are eligible for testing. But we do see sometimes people who have already got renal failure due to diabetic kidney disease probably don't have a rare kind of diabetes, but if they're close to diagnosis, they don't have other complications and they've got renal cysts, then there's a possibility. So.
So I have a question. I wonder, you've mentioned ethnicity and the Exeter MODY calculator, but I just wanted to find out how inclusive is current research on MODY in terms of the diverse populations for diagnosis and treatment, and what efforts have been made to ensure that the findings are applicable to all groups?
Yeah, really, really good question. And it's definitely an area where there's a less research than it's a research gap basically. We did a systematic review on monogenic diabetes and precision medicine and in the last couple of years, and probably about 20% of the papers that we included in our review were from people from non-European populations. So you can see that when those are the populations where type 2 diabetes in particular is so much more prevalent. And we're talking about 20% of people in India having diabetes now, compared to about 10% in European populations. We can see that it is definitely a research gap. There is a UK study which was based out of Imperial College by Shivani Misra, who's one of who's one of the people involved very much in young onset type 2 in the UK as well. And that study was called the My Diabetes Study. It's going to be published soon, we hope. And it's looking at this very question, who are the people who've got MODY? We think, based on evidence from all these studies, that probably BMI is going to be the best discriminator from young type 2, whatever your ethnic group is. And it's not a very good discriminator because lots of people are overweight now. So, you know, we're going to still miss people by using BMI as our criteria. So.
There are no other questions there. I suppose, thank you so much for your presentation. It's been really fantastic. I'm just going to, and really thank you to everybody for joining. So I hope you all found the presentation as informative as I did. I'm just going to share my screen because I just have a bit more information to give out to everyone. So firstly is to ask you all to complete our post-webinar feedback form. It's really important for us to ensure that we are providing information that is required and relevant for you all. And then the other thing is, and I urge you all, for those who don't know much about genomics and genetics, that if you want to learn more, you can sign up to our newsletter, and we've got resources and all, and that is through this link. So I think there's nothing more, but again, just a final thank you very much, Dr. Owen, for your time today. And we can probably close.
Thank you very much, everybody, and please get in touch if you have any questions that you think of afterwards. So, thank you very much.